section.
All right, we're going to talk about some thoughts on suturing, some ways not to suture, some ways that maybe help you with suturing, some ways that might not be helpful to you personally, but just my personal thoughts on how I suture in my private practice. I do almost all interrupted sutures. My thought process is belts and suspenders. If the belt fails, I still have the suspenders. So if I have two uninterrupted sutures and one of them fails, I still have the other one. If I do something where I have a more complex suture and it fails, I lose maybe the whole thing. So I'm holding back whatever I need to hold back to get access, whether that be a cheek, a lip, tongue, if you're down here. My assistant's really not doing much right now. I might need some suction, but at this point, hopefully there's not much bleeding for the patient. We've taken out, looks like 2 teeth here. In a perfect world, we're going from the outside in on our flappy tissue. We've got a 4-corner flap here with 2 vertical releases. So I'm going to go from the outside in with my first pass. Notice it didn't go super well because I didn't plan very much in advance. So your goal, your needle driver at the angle that you want it, and then push and twist. For a lot of people, a 3/8 circle suture works a lot better than the half circle suture because you can drive it a little bit more versus twist it. Personal preference probably doesn't make a whole lot of difference for most students. Sometimes you can go in 1 full pass, sometimes 2, totally depends. I like to get about 3 inches-ish of a tail. You notice the tail disappears into the mouth. Inevitably, you're going to have patients that have beards, and it looks exactly like the patient's beard. So make sure you're keeping track of your tail. At this point, maybe the assistant is holding on to the tail. I want to grab that there. They can hold on to that, control that. They're staying away so I'm not accidentally stabbing them. I'm still holding back the lip. Now, if I'm doing 2 passes, I need to readjust. I go inside out on the attached tissue. Pull through, and I've got my suture where I want it to be. I almost always will do my buccal to lingual sutures before I do my vertical releases. It helps to establish where the vertical release needs to go back to. It just makes your life a little bit easier. So at this point, I need a 3rd hand. I don't have one, so my assistant becomes my 3rd hand, and they're holding that. They don't really need to hold the tail anymore because they've maybe pulled it outside of the mouth so it's not randomly back here, sitting on a tongue, sitting on a cheek, something that's harder to grab. So they've pulled it out here. It's where I need it to be. I grab my suture. Now, you can have the suture dangling like this and maybe accidentally give someone a nose ring or a lip ring, stab yourself, stab your patient, stab your assistant. Personally, I like to hold like this. You've got almost to the edge of your cutting surface on your suture. If I'm holding that and I hold it appropriately and I don't mess with that and move it around, I'm never going to stab myself, I'm never going to stab anyone else. Now, if you have a long suture that hasn't been used like this one, there's a lot of stuff here. So if I'm doing passes, there's a lot of extra stuff. It's hard to say how much I've done. I'm trying to find things, and sometimes we get knots that stick on your needle driver. So if it's my first one, I'm going to do at least 1 3-finger pass around to make it a smaller suture. Now in this case, I probably can go 1 more even. Just makes your life a little bit easier of getting through with your passes. So your double pass towards yourself or away, your choice. I always go towards myself, that's just the way I am. Grab the end of your tail. Do not grab the tail here. Grab the very end. It's easier for it to slide through. Slide through, and at this point, we have the basis of our knot. If we want our knot to be more buccal, we can shimmy it over there. If we want it to be more lingual for some reason, we can shimmy it over here. The tightness is dependent on this first throw. We don't want tension in our knot, so we go maybe a little bit tighter than we want and let it relax a tiny bit. It stays there because we do the double pass. I let go over, grab, pull, back towards myself. Textbook says 1 more pass than the gauge of the suture. So 3/0 gut, we need 4 passes, 2 towards, 1 away, 1 back. I got 4. And at this point, I've got a knot. I go like this, and my assistant with their other hand will snip that knot. I'm done. Now, if I'm doing my vertical release, I'm back to holding it. We've got unattached tissue here and attached tissue here. ideally, we start on the flappy tissue, the unattached tissue that you've raised as a flap. Get through. This type knot probably will not be super helpful for me, but sometimes you can do a single pass through both of them. Notice this is the vertical release right here. I was able to do that, but this tissue here that's still attached to the bone sometimes is pretty thin or very attached. It's very difficult to get through there without doing some sort of release. If that's the case, before I go, I might go in here and just kind of shimmy away a little bit of that attachment and peel it off of the bone just a little bit. This is already nice and released through here, more distal, but cheat a little bit to make it easier to suture so you have less trauma to the patient overall. So I got through. Sometimes you need to release and keep pulling. Now it's nice when you're on the buckle because your tail shouldn't be too far away from you. Again, I need my third hand so my assistant holds it. Now notice he's grabbing with his left hand. His right hand becomes almost worthless to us at this point. So ideally, if you're a right-handed person, your assistant's on the left side of the patient, they grab with their left hand to hold this back. Sorry, I'm flipped now. Grab with the top hand, so right hand in this case. We're filming this at Friday at 4 o'clock. So I've got the tail where I want it to be. I've got lots of suture left, so if I need to do 7 sutures, I'm going to use 1. That's the best cost-effective way. I grab and I make sure that I'm grabbing my suture where I want it to be. Still have a lot of suture here. I'm going to show you what happens when you don't get rid of some of the length of the suture. So if you have lots of suture here and you're going through and you grab at the wrong point, now what happens? I can't really pull that through where I want it to be, and I get this tight knot that's still on the needle driver. I'm not going to be able to get that where I want it. So if that happens and you notice, just back yourself out. I'm going to do 2 throws. Try to be as close to the end of the needle driver as I can. I don't want to catch on this joint or this joint. Grab the end of the tail and establish my knot. Get the tightness that you want. There. Sometimes it does not want to go where you want it to. Helps when it's lubricated as well. I got it where I want. It's established. It's the tightness that I want. Go here. My assistant snips it. I'm good with that. If I want to do some sort of 4-corner suture, I want to do 2 interrupteds for the distal side and the mesial side, you can definitely do that. Start on the buckle. Now, this makes no sense for me to go across the patient's chest from their cheek back towards myself to go through this papilla. It works, but it doesn't work very well. So your goal is always to be as close to yourself as possible and far away from anything that you're going to be able to hurt on the patient. So I have good access here. I'm as close to me as I can get. I drive my needle and then I twist. So go through, establish the length of the tail that I want. Sometimes at this point you need your assistant to grab a hold of the mirror, sometimes not. Now, this is a tough part. If I try to do this into the lingual, I don't really have a good angle and there's teeth in the way. So reestablishing where I want to be with a top grasp. Hopefully not putting your head way over like I'm putting right now, but just to see with this mannequin. So I've got something going from the distal buckle to the mesiolingual. My knot's going to be on the buckle. Almost always you want your knot to establish on the buckle. Stays away from the tongue. That gets very curious when you have random little hairs essentially in your mouth. Not as likely to be near food, not as likely to be near temperature extremes because of food and drink. Usually knots are going to work very well on the buckle. So I've gotten through at my diagonal. I'm going to go back through the distal lingual. Didn't get probably quite deep enough into that tissue, but for demonstration purposes this is going to work. Now at this point I have a nice smooth suture on the lingual portion of this socket. There's no knot there. Comes out, goes back in. This is attached tissue. That's not going to be annoying to the patient. Reestablish here. And this is where a lot of people go and get underneath a suture, and it gets more complicated. So make sure that you're not accidentally creating an extra knot. So make sure that you're not accidentally getting under your tail, you're not tangling things through here, you're not accidentally getting through suture there. Establish here. If you look into the socket, I essentially have an X across the socket. This will help keep in bone graft material, gel foam. It'll help to establish a better clot. And then again, I need a third hand, so my assistant grabs. I probably don't need to double back. I don't have enough to work with, but I've still used the same suture. Much more cost effective. Go in here. Now here, I'm going to demonstrate. A lot of people will go like this and just drop it as they're going, and then they're trying to grab at things. You don't want extra earrings. So again, trying to grab a hold of that needle where it's something you are 100% in control of, and not having problems with it being in places you don't want it to be. So a lot of people, after they do the throw, if they're not holding there, it's over here, and I don't have any vision on that whatsoever because my hand and my wrist are in the way. But it doesn't matter if I don't have vision on my needle if I'm holding it. Obviously, you got to be careful that you're not accidentally stabbing yourself. I did an extra throw there just for fun. Establish. And looking here before we snip the scissors, we want to make sure that we have a nice tight knot, but not a nice tight suture. We don't want tension in the suture, but we do want good tension in the knot so that it stays. Because these will unwind over time if they're not tight enough against each of the throws. So when I pull like this, I want to make sure that I see a nice dense knot and not three knots that are kind of close to each other. Did a pretty good job with that. We don't want to snip it way, way high. So if he's going to take the scissors really high close to the needle driver, you're going to establish some really long tails that that patient's not going to like. That's going to be annoying to the patient. If that happens by accident, the best way to do this is to just grab and have the assistant snip that spot again. Now you notice that we only had the one. If you grab both at the same time, you can make that happen. But don't snip too low. So if he goes too low here, he might actually snip the knot. So let's actually do that so people can see. A little bit lower, a little bit lower, a little bit lower. And if he snips there, that's going to come out real easy over time. And it's a dry suture, so it's not actually going to come out here. But if you snip the knot by accident, less likely to stay for a long period of time. Those are my thoughts on suturing.